So for these soft tissue cancers in adults, we use a combination of surgical therapy, radiation therapy, and chemotherapy. The treatment of the tumor, of the primary tumor, which is the tumor where it originally started, oftentimes in an extremity, is often a combination of radiation therapy given initially to try to shrink the tumors to make the operation a little better, and then to follow that with a surgical resection. After that, chemotherapy is used selectively depending on the individual situation.
Well, in pediatric sarcomas, there is a long tradition of that's demonstrated that they are responsive to chemotherapy. So chemotherapy gives us the opportunity to first to see how they respond, and two, potentially to decrease the size of the resection or the size of or potentially the size of the radiation field.
If you do a surgical resection, you oftentimes take out muscles. You oftentimes deal in proximity to joints. And when you irradiate, you also irradiate the normal musculature, the joints, the nerves in those areas. And trying to preserve the function of those tissues are really critically important. And it requires a multidisciplinary team to do that. For me to understand where the surgical resection is going to be, how it's going to be performed. So any side effects from therapy are not adding up, and we're not getting a surgical complication in addition to a radiation toxicity. And the surgical procedure is critically important because that is often requires a combination of work with the plastic surgeons being involved, both for closure, being able to preserve the neurological function of tumors that are sitting right on top of a nerve. And so there are some very complex interactions that need to occur. And when you see a lot of these patients, you understand those. The surgeon, the plastic surgeon, the radiation oncologist are all working together to try to accomplish the same goal of curing the tumor locally, not having it come back locally, but still maintaining good long-term function.
So clinical trials are critical to advance the way we treat these diseases. And this is particularly true, as Dr. Tepper said, because many of these tumors are fairly rare. And in order to take an idea all the way through to testing and to evaluation requires having sufficient numbers of patients, and that requires doing it in the context of an organized clinical trial. Some of the biggest advances that we've made in sarcoma treatment have been exactly through this approach. So going back to the 1970s when chemotherapy was instituted, or even before that, single drugs were used and demonstrated responses in small numbers of patients. And it was with the incorporation of large clinical trials that we could finally test combinations of drugs at different dosing intervals, for example, or in combination with radiation or surgery or both, that finally led to some of the improvements in therapy that we count on right now.
It is not that many years ago that amputation was the standard therapy for most adults with sarcomas in the extremities. And through clinical trial work, we now know that that is not necessary in the vast majority of these tumors, that we can almost always preserve function of the extremity while having the local control of the tumor.